Well, good afternoon, good evening, everyone. I'm Dr. Rob Murphy, and I'm the Executive Director of the Havey Institute for Global Health here at Northwestern. I'm also the John Philip Fair Professor of Infectious Diseases and Professor of Biomedical Engineering and Medicine at Northwestern. Thanks for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health's seminar series. Today's title, as you can see here on the screen, TB in South Africa, from Gender Equity to Case Finding and Diagnostics. Please take a moment to follow us on Facebook and Twitter at #FSM Global Health. In addition, we welcome you to become an Institute member if you aren't already, to receive access to specialized resources and services that support research infrastructure. For more information, please visit our website at globalhealth.northwestern.edu/members. Today, we're thrilled to have Professor Andrew Medina-Marino, who's a PhD from South Africa. He's joining us today. He's lived and worked in South Africa since 2011. He's a principal investigator at the Desmond Tutu Health Foundation, honorary associate professor at the University of Cape Town School of Medicine, and adjunct associate professor at the Perelman School of Medicine at the University of Pennsylvania. At the Tutu Foundation, he co-leads the Division of Men's Health and is spearheading a new research site in the Eastern Cape province. His research focuses on men's health in the context of TB, HIV, and mental health. His TB research includes implementing molecular diagnostics, hence his relationship with our group here, for community-based active case finding, multi-level modeling of the impact of stigma and other social determinants on the TB care cascade, developing male-centered interventions to decrease gender disparities in TB outcomes, and integrating TB care and mental health services to improve treatment outcomes. His HIV research focused on increasing access and adherence to PrEP among young women and implementing U=U messaging interventions to improve cisgender heterosexual men's uptake of HIV testing service and retention and care. He's PI of the Tutu Foundation's new D43 PhD training program, congratulations, which will train the next generation of HIV researchers at two of South Africa's historically disadvantaged universities in the Eastern Cape. There's going to be plenty of time for questions afterwards. We welcome you to please submit your questions in the Q&A feature at the bottom of your screen, not the chat box, but the Q&A feature. It's a lot easier to do the questions that way rather than having this big a group trying to do it real time. So please put your questions there in the right-hand corner. And now, Dr. Medina-Marino, I turn it over to you for your presentation, and thank you very much for joining us today.
Great. Thank you all very much. I just have to say quickly that I'm really sorry I couldn't be there in person. I was due to fly to Chicago, and my husband and I have been in the process of adopting, and our son came to us on Monday. So no way for me to get to Chicago and pick up my new baby. So I'm doing this virtually, but really quickly, I also was a EIS officer in Chicago, so I have a very special place in my heart for Chicago. So I was looking forward to being back there, but unfortunately not this time. With all of that said, let me shut off my video and let me start my presentation. Meg, can you see my presentation?
Yeah, we can see it. It's not in presentation mode though. Yeah, there you go. Perfect. Thanks.
Okay, so I'm going to talk to you today about the work we're doing regarding gender equity and case finding and diagnostics. It sounds like they might be very different from each other, but I'll explain how they intersect with each other. Just to give you a quick picture of South Africa. So South Africa has 9 provinces. There's 3 provinces that are historically advantaged, especially with regards to their research infrastructure. And usually people think where all the great research in South Africa is coming out from is Durban, Johannesburg, and Cape Town. The area we work in is Eastern Cape province, and Eastern Cape, unfortunately, ranks last amongst South Africa's 9 provinces in terms of its Human Development Index score. It has the 2nd highest HIV prevalence, the highest TB prevalence in the country, and some of the poorest outcome metrics for HIV, TB, maternal child health, health service delivery. unfortunately, it also has a very immature research infrastructure. So I mention all that because in 2020, the Desmond Tutu Health Foundation decided to set up one of its research sites in Eastern Cape, specifically to support clinical trials and investigator-initiated research in the province. The whole idea is typically most of the HIV and TB research trials in South Africa have typically been done in Durban, Johannesburg, Cape Town. And so the voices of citizens and communities in Eastern Cape were typically not represented amongst those. When you think about something like PrEP was rolled out as a clinical trial medication back in 2007-8, and it only came to Eastern Cape as part of programmatic implementation in 2018. So it's a whole decade that they lost potentially having access to such medication. Obviously, also the research site was set up to investigate key public health research issues, to provide targeted interventions for Eastern Cape communities, and also, as all good public health researchers, to provide the local government actionable research in which to inform their programs. Sorry. Meg, I have a bar at the bottom of my view. I'm wondering how I get rid of that.
I'll jump in. I believe that if you click on the three dots on the side of the bar, and I can't see it myself, or we can't see it, but I believe you can hide the share screen bar. It's like, that's one of the options.
Okay. Okay, I can't figure it out. Anyway, so to give you a quick global overview of TB, so TB is the leading cause of death globally from a single infectious disease. Unfortunately, it has taken back that #1 spot from COVID. And in 2020, there were an estimated 10 million people who developed TB, of which 5.8 million cases were diagnosed. 1.3 million of those were amongst people with HIV who died from TB. And there were about 250,000 people who died due to TB who are co-infected with HIV. And there's about 4.2 million cases of TB that were not diagnosed or reported. Ultimately, they were missed by the health system. So here's just a quick image of the global incidence of estimated incidence of TB back in 2019. So as you see in the yellow circles are those regions of the world that have exceedingly low incidence of TB. And then you have the areas circled in red that have very high incidence of TB. So I want to give you just a quick comparison of what's going on globally in the US and South Africa. So this gray line here represents the global incidence of TB between 1990 and 2019. And back in 1990, there was a 161 per 100,000 cases of TB globally, and it's decreased very slowly to 2019 to 130 cases per 100,000. In comparison, in the US, which is represented by the yellow line, it went from 12 cases to 3 cases. In comparison, what's going on in South Africa is what you see here in the red line, which topped out at around 2007, 2008 of 1,270 cases per 100,000, and is decreased to about 615 cases per 100,000. So obviously this curve, you see this huge increase, and that was all heavily driven by the HIV epidemic in South Africa. And where you start to see the curve go down is where the country started to implement the national ART program. So two of the big things that this curve is hiding is actually TB's significant gender disparities and the large portion of missed cases. So the global burden of TB actually rests amongst men. Unlike HIV, where the burden rests amongst adolescent girls and young women, TB is solidly, the burden is amongst men. In 1998, the WHO TB report actually showed data that men had a higher TB incidence compared to women, but it was only in 2013 that they actually put words into their TB report saying, oh, men have a higher incidence of TB compared to women. And in 2019, 10 million people fell ill with TB disease. Of those, 56% of all cases were amongst adult men, whereas 32% of cases were amongst adult women and about 12% amongst children. So this really belies the fact that the burden of TB really rests amongst men globally. When you look at the case notifications by age and sex, what you see is in the white rectangles is the total estimated number of cases, and then in green and purple are the cases that have been detected and reported. Green is for men, purple is for women, and that white area between the gray box and the green color would be the estimated number of missed cases. And so ultimately there's a huge gap in terms of case detection and reporting amongst men. And men are actually about 70% of all cases that are supposedly missing or missed by the health system. This is typically implying that women are likely accessing diagnostic services more efficiently than men, but also that men are not benefiting from the gender equity or gender transformative responses that are more typical of global health, or specifically more HIV. And this is belying the fact that we need more strategies to improve access and uptake of health services amongst men. And just in case there's any worry that there might be some countries that are outlying and maybe that's what's pulling this global burden amongst men, what you see here is the male to female TB prevalence ratios of all national TB prevalence surveys done between 2007 and 2018. And all of them have a sex ratio where men have a higher burden of TB compared to women, with the low in Ethiopia of 1.2 cases amongst men for every one amongst women, to a whopping 4.9 in Vietnam male cases compared to female cases. So with regard to TB and men's health in South Africa, so as I'm sure all of you know, South Africa is unfortunately the global epicenter of the TB and HIV pandemics. With regards to TB, the general prevalence, as calculated by the recent 2018 National Prevalence Survey, was 737 per 100,000. And amongst those that were older than 15, it was 825 per 100,000. 58% of all TB cases in the country are living with HIV, and only about 50% of all cases successfully complete treatment. With regards to HIV, unfortunately, South Africa has the largest absolute number of individuals living with HIV, with the general population prevalence of 14%. The prevalence amongst those 15 to 49 is 20%, and this comes out to about 7.9 million individuals living with HIV, of which 4.8 million are on ART. So with regards to TB in South Africa, so again, the National TB Prevalence Survey in 2018 found a prevalence ratio between men and women of 1.62, meaning 62% of all cases are amongst men, or 1.62 cases of men compared to women. TB is also responsible for a very large portion of the differential life expectancy between men and women. So among the 11.2 year life difference amongst those with HIV, 81% of that life difference between men and women is attributable to TB. And amongst those who are not living with HIV, there's a 13.1 year life difference, and 43% of that can be attributed to TB. So in general, in South Africa, men are more likely to be delayed in their access to testing and care for TB symptoms, die while engaged in treatment, and also be lost to care following treatment initiation. So this is a basic curve of TB cases in South Africa by gender and age group. So you see here in yellow, the number of cases amongst females, and amongst men, it is in red. So significantly higher number of cases amongst men. Obviously, as public health folks, we like to look at things per 100,000 population. So in terms of the incidence of TB by age group and gender, we see here in yellow those amongst women, and for men in red. So the WHO considers a high burden country to be countries above 100 cases per 100,000. So as you start to see this black line, men approaching that 1,000 cases per 100,000, it's telling you that this is seriously an emergency. So when we look at the incidence of TB by province, I'm pointing this out because remember I said how the historically advantaged research centers typically are Durban, Johannesburg, Cape Town, and the overwhelming majority of all TB cases, the overwhelming majority of TB research, specifically clinical trials, is typically happening in one of these three historically advantaged research sites or centers. So when we look at Gauteng province, Gauteng actually has, which is where Joburg is, Gauteng actually has the lowest prevalence, the lowest incidence in the country in terms of provincially. So when you then look at Western Cape, which is where Cape Town is, it starts to get higher, about men topping out just above 1,000 cases per 100,000. When you then go to KwaZulu-Natal, which is where Durban is, you see a similar trend to what's happening in the Western Cape area, which is Cape Town. Now, when you look at Eastern Cape, it is starkly, significantly higher in terms of the burden incidence of TB. Now, why are the research, all research funds, donor funds, typical research infrastructure brought to Durban, Johannesburg, Cape Town? Unfortunately, this is an issue of the historic legacy of the apartheid, racist apartheid regime, which really did allocate resources to very specific regions of the country and also very specific universities. So given gender disparities in TB prevalence, uptake of diagnostics, testing, treatment initiation, and outcomes, what we tried to do is we tried to identify and implement an intervention that could address the gender disparities specifically amongst men. Now, one of the things that we did, which turned out to be an interesting exercise, was we started looking through the literature to identify interventions that we could adapt or take components of that would be beneficial for men. And so we looked at this systematic review and meta-analysis. So this paper had come out in 2018 when we started to do this work, and it identified 129 papers, and they had a number of adherence intervention categories that they were looking at. Directly observed therapy, treatment reminders, patient education, staff healthcare worker education. So what we did was we did a deep dive of all the papers that were in this meta-analysis published after 2005, again with the idea of trying to identify interventions that may have worked for men, where if we adapted it for the local context, it may have, it may work better, or at least to identify components of the intervention that men preferred, or adapt or combine interventions from different interventions that were published. The problem with this was, of the 129 papers that were in this meta-analysis, there were only 76 that were published after 2005. Not that bad, but the big problem was, of those 76, only 17 stratified their results by sex. Now, of those 17, 13 had shown improved outcomes of the intervention compared to control. Now, the issue there was, in 8 articles, men did better than the control, but women did much better than the men. In 5 articles, there was no treatment effect of the intervention amongst men, meaning that the overall intervention was being driven by improvements in outcomes amongst women. And at least thankfully, none of the interventions showed men doing worse than the control. So at worst, this is an uneven reporting of sex disaggregated results that actually perpetuates and ignores the gender disparities in TB. And at best, the poor reporting of sex disaggregated results made it difficult to identify interventions that we could either adapt or optimize to improve men's TB-related outcomes. So this brought us to the first study I'm going to tell you about. This was exploring men's wants and needs for male-centered TB care and treatment support intervention. So the study had 2 aims. It was a small R21. The 2 aims were to investigate how men and women's experiences during TB care and treatment informed their impact their preferences for gender responsive interventions. And the second aim was to develop a discrete choice experiment to try and really hone in on the components and modes of delivery that men or women would prefer. For the purpose of this talk, I'm just going to focus on the first aim. So the study approach for aim 1, it was a prospective cohort where we identified individuals initiating treatment or currently on treatment, And we followed them up until they had one of inherent three outcomes. Either they remained on treatment a month after we recruited them, they recently completed treatment, or they were at risk of being lost from care. And the way we defined that was any individual who missed 15 days or more of a visit to pick up a refill of their medication. We did this in the Buffalo City Metro Health District, which is in Eastern Cape Province. We included both men and women above 18 years of age. We did quantitative and qualitative in-depth interviews. Behavioral framework we used was the network individual resource model, and the type of analysis we did was a constant comparison approach. So the prospective cohort, we recruited 500 individuals with the hope of being able to interview 180 individuals, of which we did. So this is quite a large database of very rich qualitative interviews of men and women. We also interviewed TB patients' key supporters, and we did focus groups amongst nurses. So let me just give a quick case study of a man that we identified in our study. So this gentleman's name was Odwa, and he was married with 2 children. He worked at a scrap metal company near the Eastern Cape Airport, the East London Airport. Odwa started to get sick 6 months ago when we interviewed him. And in his interview, we asked him about how his illness affected his work. And he responded, mostly it was the coughing. At my work, I work with a blade that's similar to the one that they use in the butchery. So I would be busy cutting a battery with one hand, and on the other side, I'm coughing. So I did have a bit of a challenge. So throughout his interview, what Odwa was explaining to us was that he was not able to do his work safely, and he actually lost his job as a result. He went to the clinic and he was diagnosed with TB and immediately started treatment. The treatment he felt was very difficult for him to take because the pills he was taking made him sick. And because his family didn't eat at the same time as him, as the time he took his medication, he felt that he didn't have that type of familial support. He also felt that being able to speak with he felt very lonely, and he wanted to be able to speak with another man who had TB. And his feeling was that by speaking to another man that understood what it means to be sick while having responsibilities to provide for his family, he felt that the other man could really empathize and sympathize. And he also felt that this other man helped remind him to take his medication since it was so new to him, or at least give him the tools or some hints on how to stay adherent to medication. So with the analysis that we were doing, one of the things that was really jumping out at us was men were talking about a desire and a willingness to support other men during their TB treatment, ultimately wanting to receive peer-to-peer support, but also wanting to provide that peer-to-peer support. With one quote from a man highlighted in the red box was, "I would show them myself as I have walked the same path," which was experiencing TB. "It's not easy taking this treatment, but I would show them a friend, a living example, which is me. I have completed treatment in front of him, and I pray that I will be a better example to him since I also come from that same situation. I have swam and crossed, and he also can swim across." So with regards to preferences, men also were very adamant about receiving or speaking to other men in male spaces where they felt comfortable talking about men's issues, and suggested that these spaces would be conducive for a conversation about TB. One of the men that we were speaking with made the following comment, highlighted in red. He was talking about speaking with men there near the community toilets, because that's where you normally find men sitting and playing dice. "You know, even if you come and stop here, and since you know me, my brother, it will be easy to come and start a conversation, and a lot of people will listen." So a third theme that we recognize men really speaking about with regards to preferences and components of an intervention was about men feeling isolated from their families and communities during TB treatment, and actually advocating for community awareness to reduce their feeling and sense of isolation. And one man actually said, "It is embarrassing to go to the next door neighbor and ask for food. Maybe there are a lot of people who want to take their treatment, but there are things that they wish they had but don't have, so they end up not taking their treatment." And this was definitely a refrain that many men were talking about, feeling isolated from their community, feeling ostracized, and wanting to have community engagement so that communities were aware of the difficulties that they face. So even though we didn't necessarily really ask men about stigma, something that was jumping out during a lot of these interviews, both men and women, were the issues around stigma. And so what we were starting to do was to compare and contrast men's and women's experiences during their TB treatments. So one of the big things, as you would expect, both men and women were anticipating stigma. And they anticipated the stigma's impact via their social networks, and they were also anticipating negative comments or judgment regarding their TB. One of the women that we interviewed, highlighted in yellow, she was saying that, I thought maybe that they would think I have TB because I drink a lot or smoke all these awful things. Like maybe they're judging me. They were not saying anything to me, but in my mind, I thought maybe they were asking themselves a lot of questions. So she's definitely getting at anticipated stigma. One of the men in the interview, which is highlighted in red, he was saying, you can't just trust everyone. Once you tell them about your health, it will be like you have committed a crime. They treat an illness as a problem. It becomes the talk of the town. So again, both men and women were anticipating stigma. Now, one of the really interesting things that we were noticing was in terms of men and women's discussion around self-isolation. So women were really talking about being isolated more out of self-isolation due to anticipated stigma. Specifically, women were concerned about gossip and perception of others. And so they self-isolated as a way to steal themselves from the type of stigma that they were expecting. One of the women said, I have to distance myself from other people. I don't feel comfortable because you don't know the thoughts of other people. They don't like it. Now, interestingly, where women were talking about isolating themselves in anticipation of being stigmatized, men were actually being socially isolated by their family and friends. So what men were really describing here was they were actually disclosing to people, hoping to get more social support. And as an act of that disclosure, men were being socially isolated. So one of the men was saying, my sister distanced herself from me. Her response was, I want to be as far away from you. When I was living with my sisters at my sister's house, I was locked in a room. I had to stay there until people were gone. This man then moved in with his elder brother into a shack, and he felt that his brother just kept giving him the bad luck. And so it's important to notice the fact that in terms of gender neutral issues, again, both men and women are anticipating stigma, but the mechanism by which that stigma impacts their behavior is actually gender specific, where men are feeling forced into isolation due to experience stigma, and women feeling isolating themselves in anticipation of stigma. Okay, so I want to sort of shift gears a little and talk about some work we've been doing in the community around taking molecular diagnostics into the community and into people's homes. And this was all done as part of case finding. So when we talk about the missing cases of TB, which isn't a very nice way to say, the cases that the health system are actually missing, because people aren't missing, the health system is missing them. So missed cases by the health system is actually a key driver of transmission. And of the estimated 10 million individuals estimated to have TB in 2020, 4.2 million of those were either not diagnosed, not treated, or not reported. And so to minimize the number of cases missed by the health system, especially in areas where TB prevalence is above 100 per 100,000 population, the WHO recommends systematic screening of all individuals entering a healthcare setting, and specifically also focusing on vulnerable individuals. Obviously, those would be people with HIV, people with diabetes, people with known risk factors. So factors associated with missed TB cases is actually individuals' health-seeking behaviors, but it could also be structural barriers with regards to accessing of health services and testing. Missed cases of TB could also be due to insufficient diagnostic sensitivity, which is a big issue amongst those with HIV. But we also have to recognize the fact that the health system fails to identify individuals who actually do present to the clinic. And we had done a study back in 2017 where we found an overwhelming majority of cases of individuals who had TB were either never screened or if they were screened, they were never tested. So active case finding as compared to passive case finding, which is, when someone passively presents to with their symptoms, case finding is shown to improve early case detection and in turn, hopefully improve outcomes. One of the ways to do active case finding is of screening of household contacts of individuals who have TB. One of the big problems with household contact investigation is the low uptake of community to clinic referrals by household contacts that are screened positive. And this is definitely a barrier to diagnosis. And finally, home-based TB testing, what we've been hypothesizing, may actually improve early case finding linkage to care. So I'm going to quickly tell you about these two last studies. One was a study to investigate the acceptability and feasibility of doing home-based TB testing using a mobile point-of-care diagnostic. And the second one is one that we're still doing on evaluating oral swabs or tongue swabs compared to sputum, and also still doing household level testing. So the study that we did that is located in an area called Duncan Village Community. It has a very large informal settlement, as you can see in this picture, and it's only about 2 square kilometers. So it's actually a very small area, but it has one of the highest prevalence of TB in the country. There's about 10 clinics serving that area, and they're all highlighted in red. And these are the clinics that we actually conducted this work in. So the 2 devices that we used was back in 2017-18, we adapted GX1 device made by Cepheid, and more recently used Omni device, which was unfortunately taken away from us by Cepheid when they decided to pull it from the global markets. So the first study is about just purely the acceptability and feasibility of home-based testing. So in this study, it was a pilot randomized trial of households of TB index patients. The idea was to randomize households into one of 2 arms, either those who were screened, and if they screened positive, tested in their home with referral for treatment, and then the control arm was screen individuals in the home and refer them for testing at the clinic. We also did this only amongst symptomatic individuals, just to point that out. So in terms of eligibility and inclusion criteria, very quickly, it was amongst those 18 years and older. For this study, it was amongst those who are symptomatic for TB, not currently on TB treatment, and of course, providing informed consent. The screening and testing procedures were household members were either screened with the standard 4-question WHO screener of do you have cough, night sweats, fever, weight loss. And we asked all individuals who were symptomatic for TB over 18 years of age to provide a sputum. Any children under the age of 18 that had any symptoms were immediately referred to a local clinic for evaluation. So this is an image of the GX1 setup. You could see the Gene Expert device at the lower part of your right-hand corner, the white box. It was hooked up to a external battery that was portable and a laptop. So it's a bit bulky, but it did the trick. You could see that we're in individuals' homes. This was set up anywhere between someone's table, on a chair, as you see here, on the floor. Sometimes homes had just a dirt floor. Other times they may have had a cement floor. So it was quite a diverse range of household setups. So in terms of the acceptability and feasibility, so we were able to identify 100 household contacts that were symptomatic. Again, this was a very small study. So of those 198 agreed to participate and provided consent. So this was telling us, okay, this is at least very acceptable. In terms of those that were randomized to the intervention arm, that was 51 individuals. All 51 attempted to provide sputum. So again, in the sense of, were individuals willing to be tested in their household? Yes. Were individuals willing to at least attempt to give a sputum? Yes. All 51 individuals attempted to give sputum. So again, this is speaking to acceptability. When it speaks to feasibility, one of the things was, again, the number of total specimens collected, which was only 24, but this speaks much more to sputum as a specimen for testing for TB and the actual feasibility of the overall home-based testing. Another measure for feasibility we were looking at was the number of valid or invalid test results generated. So amongst the 24 tests that we conducted, 23 had a valid test result. The one that showed an invalid test result actually was the very first test we ran. So kind of chalk that one up to experience. So when we look at the TB testing cascade, we see in yellow highlighted that those individuals in the intervention arm, in red, those individuals in the control arm. So there were 51 symptomatic individuals in the intervention, 47 in the control. Amongst those, in terms of the step in the cascade, those presenting for TB testing. So obviously when we're in someone's house, and they said, yes, you could test me, inherently all 100% of them presented for testing. But when you look at the referral uptake of someone who's symptomatic for TB and referral for testing at the clinic, only 15% of individuals presented to a clinic. And unfortunately, this is not too surprising, at least in the South African context, when you try and do this in a programmatic setting. So then when we look at the number of individuals actually tested for TB, amongst those in the intervention arm, about 50% were actually tested. In the control arm, only about 13% were tested. In terms of those who actually received their test results, 96% of the intervention arm received their test result. Only 66% of those in the control arm received the test result. Obviously, these are very small numbers, but the time from when someone was screened to when they got their test results inherently was 0 days in the intervention arm, and it took a median of 16.5 days in the control arm. The number of individuals identified with TB, there were 3 individuals in each arm who tested positive for TB, and 2 in each arm initiated treatment. These are small numbers, but the thing that we were happy to at least see is those who tested in the house of those who presented, they presented within 1 day. Whereas for those who were referred to the clinic and had to initiate treatment, it took a median of, it took 39 individuals, 14 days for another. So, a significantly more number of days compared to intervention, but small numbers. So let's not make too much of this. So now the next study is speaking to doing the study, not necessarily as an RCE, but to evaluate tongue swabs as a specimen for testing, but not only tongue swabs as individuals, but being able to pool tongue swabs for a single household. Because if you think about it, if you're in a household and there's 5 individuals who need to be tested, running 5 tests could take a lot of time. The Gene Expert device takes about 90 minutes to run each test, depending on how many devices you bring in. It could take, if you bring in 5 devices, it'll take an hour and a half, 2 hours. But if you now get up to 6, 7 hours, 8 hours, which would be completely unacceptable. So the idea here is if we had a household level triage test for household contact investigations, could this actually improve on the cost effectiveness? And this again was just a pilot study. So again, it was a similar longitudinal cohort of the previous study. We again did it in the same location out of the same clinics. The specimens that we were comparing was sputum versus pooled oral swabs. And this time we used an Omni device, but halfway through the study, it was taken away. So we went back to the GX1 device. The difference in this study was TB symptoms was not an eligibility criteria. We noted them down in the database, but you did not have to have TB symptoms in order to be tested for TB here. And in terms of the number of specimens, we asked all households to please provide 2 oral swabs, 1 for immediate pooled testing in the household and 1 to be sent off to the lab for lab-based testing. Okay, so in terms of the specimens, again, we used pooled oral tongue swabs for 1 specimen, and we used sputum for those who were able to provide sputum. Household recruitment, just starting at top, we recruited 478 index patients in the clinic, those we ultimately enrolled 631 contacts. You could see that towards the bottom highlighted in red. Of those 631 contacts from the 478 index patients, 630 agreed to be tested in their home. So, nearly 100% acceptability of being tested in their home. So when we look at the specimens provided, so amongst those 630 contacts who consented to be in the study, 620 gave tongue swabs. So that's about 98%. But amongst those who we asked for a sputum, it was only about 38% who were able to provide a sputum. Now, amongst those who provided a sputum, you can see in your bottom right-hand corner, 26 of those, of the 241 that we actually have test results for, tested positive. So a test positivity of 10.8% in household contacts is actually pretty darn high. With regards to the individual tongue swabs sent up to the laboratory, we had 31 of those 517 tested positive for a positivity of 5.7%. So one of the big things to take away from this is amongst those who had a positive sputum test results, obviously we wanted to take a look and compare to what we saw in the previous study. How quickly are they taking up referrals, and are they taking up referrals? And one of the really nice things to see here with the larger sizes, amongst the 26 individuals who tested positive in their house for TB, 100% took up the referral, and there was no additional intervention for, support for uptake of the referral. So there was no behavioral nudge, there was no driving them to a clinic immediately. They went on their own accord after giving them a basic referral. In terms of the time to clinic attendance, the median time was 24 hours, with the range being 24 to 72 hours. So again, this is a very fast uptake of a referral compared to what's in the literature and what we saw in a previous study. So now when we look at the comparison of paired sputum to individual swabs tested in the lab, unfortunately, the sensitivity is not as optimal as we would like it. The current sensitivity of our protocol is sitting at around 53-54% sensitivity of individual swabs tested in the lab compared to sputums tested in the household. Now, one of the things that this is actually hiding is the fact of the contribution of tongue swabs to TB case finding. So when we look at the 387 individuals that could not produce a sputum, 12 of them had a positive tongue swab result, which speaks to the increased yield that tongue swabs could provide that sputum cannot, because of the difficulty in producing sputum. So that's an increased yield of about 3.1%. So now when we look at sputum versus pooled swab test results, there were three types of pooled swabs done in the house. There were households where there was only one individual present when we were doing this, so we only tested their individual swab in the house. Then we were able to pool 2 swabs together and 3 swabs together. There were households that actually had upwards of 12 individuals present all at once. And so what we would do is we would only do a maximum of 3 swabs per pool. So this is actually not a result of household level, but just a pooled swab level. So I'm not going to show you the 2x2 tables for the pooled swabs, but when you look at the individual home tested single swab compared to the sputum done in the household of that same individual, 100% sensitivity, but the number is rather small. When we look at the 2 pooled swab, the sensitivity drops significantly down to about 41-42%. When we had 3 swabs in a pool, the sensitivity dropped, unfortunately, even lower to 33%. Now, the interesting thing here that gives us a little bit of hope is when we looked at the sputum that were associated with each one of these swabs from the individual, what we noticed was the sputum that was tested in terms of the expert readout. There's the high, medium, low, very low, and trace level detected. All the sputum that were associated with the swabs in those pools either had low, very low, or trace detection. So this was telling us partially that perhaps it may be an issue of dilution. The other issue is obviously Gene Expert and Ultra is optimized for sputum testing, not swab testing. So ultimately, in conclusion of the studies that I've mentioned, with regards to the TB in men study, male-centered interventions to improve outcomes should ultimately include peer-to-peer support, include awareness events to educate community, and be delivered in familiar locations where men are congregated. These shouldn't necessarily be a epiphany to people, but the fact is that to date, no TB support intervention have ever included the preferences or components or modes of delivery that men were actually describing in our study, which says that for this purpose, men's voices aren't necessarily being heard in regards to TB care and support interventions. With regards to stigma, we're definitely seeing that the gendered impact of TB-related stigma on individuals' behaviors. And we're about to receive a R34 to adapt a intervention called Coach and Pila, which was originally developed for men with HIV, and we're adapting it for men with TB and TB-HIV. And finally, with regards to the conclusions and next steps for the home-based TB testing, we definitely see that there's high acceptability and feasibility of home-based testing. We also see that home-based testing may actually significantly improve upon the current household contact investigation approaches typically used, and this would include referral uptake, the proportion of referrals taken up, and the time to clinic presentation. There was unfortunately a poor concordance of pooled swab specimens, but right now we're looking at this as potentially an issue of bacterial load and specimen dilution, and we're back in the lab trying to optimize this. In terms of, we're also trying to currently optimize the protocol for both single and pooled swab testing. And finally, we're starting to look at and explore other diagnostic platforms for use in home-based TB testing. And with that, I thank you very much. And I open for questions. Thank you.
Thank you, Andrew. That was so interesting. And we've got a few questions in the chat, and please put in the other questions you have. And I'll do my best to try to contextualize any of the questions. So if I don't get it, then put a reminder or something in the Q&A for me. First, Adil Menon, he wanted to tell you congratulations on the adoption of your baby, but also he is interested at looking at interplay of co-infections with TB as well, and his particular interest is with co-infections with helminths. So that's something maybe you guys can pick up after the seminar, if you have, to express your shared interests. Kenneth Soyemi, I guess, he asked, has TB led to excess mortality in the Eastern Cape? He wondered what the life expectancy of males in the Eastern Cape is, and what's the population distribution of the region. So I guess wondering what the extent of this issue is.
So the study that I cited with regards to the difference in life expectancy between men and women due to TB, that was done in a demographic health surveillance area in KwaZulu-Natal. In terms of the national statistics, it definitely shows that TB is a driver of mortality amongst men. What it looks like specifically in Eastern Cape, I'm not necessarily sure. I would probably argue that it's easily the same of what's going on in KwaZulu-Natal, if not potentially worse. In terms of the population distribution in Eastern Cape, Ken, I'm happy to send you the graph of that, but I don't necessarily know it offhand. Did I miss any of his questions?
No, I think you got it. So
okay.
We have another question. This person is asking themselves, why do we see the higher prevalence among adult men than women? And I noticed that too, that it doesn't start until they're adults, like in children. It looked like it was pretty evenly distributed. And it seems like it's a bigger problem in adult men. And it's throughout the world, right? So
yeah. this is definitely a global phenomena. And with regards to the higher burden amongst men compared to women, so my understanding is when you look at latent TB infection, the prevalence of latent TB infection is pretty 50-50. So it's more an issue of progression to TB disease amongst men compared to women. Now, there's definitely work out of a few groups at Hopkins that are looking at biological issues and immune response, and they're starting to detect some differences between that's due to sex hormones. I'm not fully clued up on that literature. I'm just starting to jump into it now. But when looking at the higher burden amongst men, especially at different age groups, it definitely speaks to the differential risk factors amongst men. And some slides that I didn't necessarily show in the talk was I broke down the incidence curve by age groups and gender just in Eastern Cape. And so in some districts, you see the prevalence skewing much older. In another district, you see it skew much younger. In another district, you see these just ginormous differences between men and women. And it's definitely speaking to the prevalence of risk factors in those particular districts. Some of the districts, especially the rural ones, are likely sending men off for working in mines or seasonal working. The curves that seem to skew lower are more in urban areas where there's higher rates of alcohol and substance use that can be a contributing factor to progression to TB disease. So this is really one of those know your epidemic kind of issues, the way the HIV community has done it. And I can't say it's been done very well for TB, either globally or definitely not in South Africa.
That's really interesting.
Andrew, that Geneva Dabitao, who got her PhD at Hopkins and is from Mali, has shown the exact same data that we did in terms of the men twice as much as women. I'm going to hook you two up because she's this is her area. She's an immunologist. Yeah, great. You got more questions though.
So here's another question. This person wants to know, in the first study, I think it's of the study of the home testing, the 4 who initiated treatment were only those with confirmed TB. Was there any clinically diagnosed TB? I guess is the question.
Yeah, so in that first small pilot RCT, the 2 in the intervention arm were those diagnosed by our testing in the household. The 2 in the control arm were those who actually presented to the clinic and were diagnosed in the clinic.
But
so
microbiome.
They were actually. Sorry, go ahead.
So they were diagnosed by testing, not by clinical observation.
Oh yeah, so the first line diagnostic procedures in South Africa is all gene experts.
Right.
Gene expert.
So Chad Achenbach has a question. Given the high HIV prevalence in South Africa, how much of the higher incidence in TB disease in men could be due to lack of engagement in HIV care compared to women? Thanks for the great talk.
That's one possibility. Sort of a flip of that is you saw the graph that I showed where all of these countries like Vietnam had a 4.9 cases amongst men compared to women. So in most of those countries where the difference between men and women was really just astronomically high, were countries that are not necessarily HIV endemic, much lower prevalence of HIV. So I would argue that you're seeing only a 1.62 ratio between men and women in South Africa because HIV is driving more TB cases amongst women. And there was actually a paper that just came out by Lee Johnson at University of Cape Town that looked at this, and in their model they showed exactly that you know the gender difference in TB would probably be significantly higher amongst men compared to women if it weren't for the HIV epidemic in South Africa. Now, in terms of the higher prevalence amongst men compared to women, you know, it's sorry, rephrase that question for me one more time, Sally.
Chad wanted to know if the higher incidence in TB disease in men could be due to lack of engagement in HIV care compared to women.
Okay, so, and I would argue just the opposite, because men have a lower prevalence of HIV. So I don't necessarily think the HIV epidemic would be driving the higher rate, the higher difference between men and women. If anything, again, it's lowering that ratio because there's a higher proportion of HIV amongst women.
But what he's saying is that the
Um,
HIV infected patients are more engaged in care to begin with. And there's more,
Right.
that's
Ah.
from the other side.
Got
It just sounds like there's
Um,
a drive, a push up for the women. And the men, but the men are not, if they were also getting care through the HIV clinic and being treated, tested and
yep.
screened for TB, they might be lower, but they're not there. So they're kind of staying where they would normally be, I guess.
I would agree with that. Yes.
Yeah.
One more
it's a lot
question.
going on there. Oh, only one more question. So I'm just
One
gonna
more question.
go through here.
By the way, I'm happy to stay online if people want to ask more questions.
I think this is an interesting question. Looking broadly at TB efforts, what more do you think is needed in terms of control efforts, such as biomedical advances, health system barriers, and social and economic factors? So it's kind of a broad question for you.
Nobel Prize one. This is the
Yeah.
Nobel Prize.
Yeah, so I try and do a lot of mixed methods in my work, and a lot of it really tries to get at the social determinants or political determinants of health. I feel the TB community is a bit more conservative than the HIV community. And so there's this constant mentality of better drugs, faster diagnostics will get rid of the whole epidemic. And I feel like there's that third point of the triangle of the social political drivers of health disparities that the global TB community just isn't as mature in their thinking about the way the HIV community is. So I think that's a big issue. There's just that mentality of better drugs, faster diagnostics.
Well, I think that we're really at the top of the hour, and a lot of people do have to leave now. So I think we'll bring this to a formal conclusion. But thank you very much, Andrew. This was really great. Thanks for taking the time to share your insight and expertise with us today. Thank you, audience, for joining us and for submitting your thoughtful questions. We're sorry that we didn't get to all of them. We invite you to join us at our next Havey Institute Global Health Seminar, which is Wednesday, September 6th. The event will feature a presentation from Dr. Alex Lundberg, Assistant Professor of Emergency Medicine here at Northwestern. He's given several other presentations to us before. And again, thank you for joining us today. For those of you who have registered, a recording of the webinar will be shared by email. And this concludes today's webinar. Thank you very much, Andrew, and thank you everyone for joining us today.
Thank you very much, everyone.
Thank you, Andrew.